So our topic is headache for today. So the first one, basically we can have two types of headache. The first one is primary headache and the secondary headache. The secondary headache is basically uh, due to some causes like this, like intracerebral hemorrhage, like different types of hematomas, brain abscesses, brain tumors, meningitis, like subarachnoid hemorrhage, hydrocephalus, glaucoma. So things like the different states or conditions of other organs or some structures in the skull, but not basically the like the parenchyma itself. And the secondary headaches are more severe, usually more complicated, and more often lead to death. And the primary headaches, they are more mild. We have maybe four classic types of headaches. It's migraine headache, cluster headache, like um, tension type headache, and sometimes the temporal arteritis. So in brain we have several structures, several pain-sensitive structures, which irritation of which can lead to pain. The first one, the scalp blood supply, so blood vessels, head and neck muscles, and other soft tissues. Great venous sinuses, arteries of the meninges, larger cerebral arteries, like pain-sensitive fibers of the 5th, 9th, and 10th cranial nerves, and the some parts of the dura mater of the base of the brain. The first one, the first one, some things about location. The headache can be hemicranial. That's like in the one half of the brain, one half of the skull. It can be bitemporal, bitemporal, in the both temporal zones. Occipital, frontal, periorbital, like across or across the eye, and sometimes behind the eye, and the vertex. What about the incidence? The migraine occurs commonly in 70% of females and 30% of males. Cluster headaches occurs almost entirely in men, in 90%. And tension headaches equally in both sexes. The first one, we will talk about migraine headache because it's the most common type of headaches and the most, I think, disabling type of primary headaches. So it's a familiar disorder characterized by periodic, commonly unilateral, often pulsatile, in the most cases pulsatile or throbbing headache. It usually begins in childhood, adolescent, in early adult life, and diminishes in frequency and severity during advancing years. Typically begins in teenage years, maybe between 15 and like 22, 23 years, and diminishes, like I said, in advancing years. We have different types of migraine. The first one is classic migraine or neurologic migraine. It is characterized by aura or aura. We can name it common migraine. It's a migraine without aura, and you see that common migraine is basically more common, uh, like its name, 5 to 1 incidence. So classic migraine have has different periods. The first one is prodrome. It occurs hours to days before headache and consists of change in mood, behavior, appetite, and cognition. Then we have an hour period. It occurs without an hour of headache and is most commonly visual or sensory. The visual aura consists of photopsias, bright flashing lights, scintillating scotomas, field scuds, and fortification spectra. Fortification spectra is basically the phenomenon when you like see some sort of castle or mountains somewhere. So you can imagine, like, you see the mountains on the like horizon, and it's a bit blurred. So that's a fortification spectra which is seen by patients with migraine. And sensory auras is the next common type of aura, and it's characterized by numbness or paresthesias in a limb. And the third one is motor weakness and aphasia, but they are less common. So about sensory and motor symptoms, it can be misdiagnosed to some conditions like stroke or multiple sclerosis or other a lot of neurological conditions can lead to some symptoms, but it can be a simple migraine. So the headache in migraine can have several distinguishing features. The first one, it is often unilateral, hemicranial in 60% of cases, and throbbing or pulsating, we call it. It follows aura with in 60 minutes and lasts from 4 to 72 hours, and is basically associated with nausea, vomiting, photophobia, it's aversion to light, and phonophobia, it's aversion to sound. Headache may be relieved after vomiting, and sometimes maybe not. It depends of specific patient, and it's aggravated by strain, routine physical activity, or rapid movement of the head. Sometimes it can be relieved with pressure or some kind of massage on temporal vessels. You can see patients which put a finger on their temporal zones to relieve the pain a little bit, and it has a strong family history. So if some relatives have this condition, so it is a big incident that children also will have the migraine attacks. And the migraine attacks come once or twice per month, from 3 to 4 types per year, but sometimes a lot more often. 3-4 times a week, or even every day. It depends of specific patient. There is a strong association with menstruation in females. There is type of, like we call it, menstruating migraine, which women can have only during menses, and it disappears when menses are finished. Oh, what about the common migraine? The symptoms are similar to classic migraine, but there are no aura. Uh, there are no aura, and there are can be some precipitating factors, like specific foods which can precipitate or even uh, provoke the pain. The first one is foods rich in tyramine or cheese, red wine, foods containing monosodium glutamine like Chinese and Mexican foods, foods containing nitrates, cold cuts, bologna, salami, smoked meats, pickles, fermented or marinated foods, alcoholic beverages, especially red wine, and caffeinated beverages like soft drinks, tea, and coffee. Uh, so what about etiopathogenesis of migraine? We had in previously we had different series. The first one was vascular theory. It states that the migraine aura is due to cerebral vasoconstriction, and since the migraine itself is caused by vasodilatation, and cerebral blood flow is decreased during migraine with aura because there is no changes in blood flow during migraine without aura. Uh, and there is a role of serotonin. Serotonin is basically a neurotransmitter, which levels of which are elevated in the blood and may decrease where urinary concentration may increase. The shift in serotonin level may trigger changes in blood vessels and blood flow, and also alter pain perception in the brain. And like I said, serotonin may play a role in the cause of migraine. Um, and therefore some types of medications will be effective in case of migraine attacks, like amitriptyline, nortriptyline, which are basically antidepressants, and also as substance P has a little effect, like activations of fibers, which basically physiologically releases substance P. Increase can cause throbbing headache. And of course, nitric oxide is which is generated by endothelial cells, has been implicated as a cause of pain. So we basically have two series, like vascular and neurotransmitter, can we call it. But now there is a strong evidence that migraine is a mixed condition. It has a vascular component and the neurotransmitter component, and the like the most modern studies can tell us that there is some peptide, we call it calcitonin gene-related peptide, that is that have that has a strong impact on causing the migraine. The levels of the calcitonin gene-related peptide, or CGRP, are a lot higher during the migraine attack, and when the attack is like reversed or finished, the CGRP levels are back to normal. So different types of we have different types of like localization of migraine. The first one is basilar migraine. We can call it basilar artery or vertebra basilar migraine. It is less common form of localization. It has prominent brain symptoms. It is seen usually in young women with a family history of migraine. It have visual aura and may even develop temporary cortical blindness. They may be associated vertigo, staggering, incoordination of limbs, dysarthria and tingling in both hands and feet and around the mouth. Exceptionally, there can be period of coma and quadriplegia, so it can mimic other conditions like stroke, multiple sclerosis, like some types of neuropathies, some types of intoxications, and the symptoms last from 10 to 30 minutes and are followed by headaches, which are commonly occipital. Some patients at the onset of headache may faint or become confused or stuporous, and this stage may persist for several hours or longer. The next type is ophthalmoplegic migraine. It is characterized by recurrent unilateral headaches associated with weakness of extraocular muscles. It can lead to transient third oculomotor nerve palsy with ptosis, with or without involvement of the pupil, and it can lead to the sixth nerve palsy or abducens nerve, but it's commonly a feature of child of ophthalmoplegic migraine. Paralysis may persist even after headache for days to weeks, and occasionally ophthalmoparalysis may remain permanent, which is of course a strong disabling condition. The next type is retinal migraine or ocular migraine, we can call it. It is characterized by retinal or optic nerve ischemia. There may be retinal hemorrhages or narrowing of retinal venules during an attack. Monoocular blindness, disc edema may occur, and vision recovers only partially after several months. As the retinal or ciliary circulation may be involved. The next type is post-traumatic migraine. Sometimes headaches, like migrainosus types of headaches, can follow some brain or head trauma. It may be it can be manifested by loss of sight, headache, confusion for hours, days before recovering, and in others there may be even hemiparesis or aphasia, which once again can mimic, for example, stroke, ischemic stroke, basically. A rare type of migraine is an abdominal migraine. We know that there is a abdominal type of myocardial infarction, for example, and there is also an abdominal type of migraine, basically seen in young children. Instead of complaining of headache, the child appears limp and pale and complains of abdominal pain, which is like funny because it's a headache type, but the chief complaint is abdominal pain. And there may be vomiting and fever. And there may be also disturbances in mood along with abdominal pain. The next rare type is hemiplegic migraine. It can be like the infant, child, or adult episodes of hemiparesis that may outlast the headache, and sometimes they can't. It has strong autosomal dominant trait with a family history, so it's a familial family type of migraine. And basically, we can say that migraine is a strong, maybe sometimes not disabling condition, but the condition which decreases quality of life very severely. It can be due to some reasons. The first one, it's a complicated migraine. We call that complicated migraine is that type of migraine which can lead to neurologic deficit. I'm sorry. Neurologic deficit. For example, homonymous visual field defects or some sensory disturbances or some motor disturbances. It's basically due to platelet aggregation, edema of the arterial wall, increased coagulability of blood, intense prolonged spasm of vessels. It leads to the arterial occlusion, and sometimes stroke can complicate the migraine. So we're talking about the permanent neurologic deficit. And some very rare types of conditions which can lead to migraine in children with mitochondrial disease like MELAS syndrome, mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episodes. It's mitochondrial pathology basically, and in adults with rare vasculopathy and CADESIL, cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. Migraine will be a prominent feature in these two conditions. And when the migraine is like aggravating and can be stopped with different types of medications, we can talk about status migrainosus. It's a continuous migraine with unilateral throbbing and disabling headaches, which can be followed by hand injury or viral headache, and it's, like I said, can be stopped with basic first-line therapy of anti-migraine medications. And of course, we should treat that migraine only in medical facilities, so in hospital basically. And as I said, there is some premenstrual or menstrual migraine. It's thought to be due to withdrawal of estrogens in some periods of women's life. Migraine attacks tend to cease during pregnancy in 75 or 80% of patients. Usually we tell that it may be even be associated with permanent neurologic deficit. Uh, and sometimes we can talk about footballers' migraine. It's due to sudden jarring of the head, which may precipitate the migraine attack in susceptible footballers. And of course, not only footballers, different sports, different motion, everyday motion activities, which can lead to the sudden jarring or sudden a little head trauma can lead to can precipitate migraine attack. Until 75% of patients can be aborted the attack of migraine with these types of treatment. And like the one of the most modern types of medications are the serotonin receptor agonists, or 5-HT receptor agonists, or triptans we call them. It's like I said, modern types of medicine. They were discovered only in 1990s. And the first one is sumatriptan. It is effective at stopping acute attacks of migraine headaches. It can be given subcutaneously, it can be given as intranasal spray or orally, and it can provide relief in 70% of patients. So it's more than half. It's a lot. Of course, it can have some side effects like chest tightness and flushing. It should not be used concomitantly with ergotamines or in patients with heart disease. Also, we can name zolmitriptan, rizatriptan. There are a lot of medications in pharmacies, a lot of triptans, like stop migraine, migraine stop, and others. Of course, we can use combined medications. A lot of them consist of dichloralphenazone, it's a muscle relaxant, isomethiptan is a vasospasm agent, and acetaminophen. It can be used as abortive therapy, 2 taps with onset of headaches, and 1 tap every hour after that, up to 5 taps total. It can also used not only for acute treatment. It can also be used as prophylaxis. And speaking about prophylaxis, it is very important to patient which have 2 or 3 attacks, acute attacks of migraine, or more, or, or even more, like every day or several times a week. They should use their prophylactic agents. It's very important in treating of migraine. The first line of prophylactic treatment is beta blockers like Inderal, atenolol, timolol, metoprolol, and other beta blockers can be used. We can use sodium valproate, 500 milligrams a day, up to 1000 milligrams a day, 1 gram. Calcium channel blockers like verapamil, nifedipine. We can use tricyclic antidepressants As I said, they affect, they can modify the metabolism of serotonin. They have some side effects as a dry mouth, constipation, urinary hesitancy, sedation, weight gain. We can use metisagrate, is serotonin agonist, a strong vasoconstrictor. It's highly, in fact, it's highly effective for primary treatment, but has side effects on prolonged use, like pulmonary fibrosis or retroperitoneal fibrosis. And if these all types of medications are ineffective, we can use other drugs like clonidine, ciproheptadine, flunarizine, indomethacin, and others. The next type of headaches, so we're finished with migraine, and the next type is cluster headaches. Cluster headache, it is also known as paroxysmal nocturnal cephalgia, migrainous neuralgia, histamine red migraine, erythromegaly of the head. It has some distinguishing features which can't be found in other types of headaches. The first one, it has an abrupt onset. The next is that it is originating in the eye or behind the eye. Sometimes patient says that someone stuck put an ice pick in my eye or something sharp, it's like lancinating, or we can call it tearing pain behind the eye, and always a temporal area sometimes, but the first feature is behind the eye. It's very severe, basically, less from 20 to 60 minutes, and often it disturbs patients at night, so during sleep. It cuts the patient's sleeping state. And the first feature is behind the eye, and the second important feature, it is associated with some autonomic nervous symptoms like nasal stiffness, rhinorrhea, redness of the eye, flushing, edema of the cheek. And there may also be partial Horner syndrome with ptosis and meiosis, like I said, anhidrosis or dishidrosis on the side of the head pain. And these autonomic phenomena are similar to those elicited by local action of histamine, and was therefore previously called Horton's histamine headaches. These headaches, as I said, are usually nocturnal, between 1 and 2 hours after the onset of sleep, and several times during the night. And they are not associated with aura or vomiting. The headaches recurs with remarkable regularity each day for periods that last over 6 to 12 weeks. And this period we call them clusters. So the cluster headaches forms some types of paroxysms, which we call clusters. Cause and mechanisms of cluster headaches, they are not totally clear. They are probably due to a paroxysmal parasympathetic discharge mediated through the greater superficial petrosal nerve and sphenopalatine ganglion. And patients with cluster, there is a mistake, not cluster migraine, cluster headache. they have characteristics of both migraine as well as a cluster headache. Treatment basically is similar to migraines. It can be used. Sorry. We can use ergotamine 2 milligrams at bedtime. We can use intranasal lidocaine, sumatriptan. We can use metoclopramide, prednisolone, calcium channel blockers like verapamil. We can use lithium and the medicine. And the but the first line therapy of cluster headaches is 100% oxygen for 10-15 minutes of the onset of the headache. And the last type of headache which we will talk about is tension type of headaches. Is basically uncomplicated type of headache. It can be seen after some stressful work, stressful studying, or after some emotional stress. It's basically the prominent feature of this headache is band aid type of headache, so like circular across the head. It is uncomplicated. It can be treated with simple NSAIDs or acetaminophen, and it usually lasts for maybe from half an hour to 1 hour, or until a patient goes to sleep. And some words about secondary headaches. Like I said, secondary headaches are usually more severe. They are caused by different conditions, as where it is like different hemorrhages. In particular, the subarachnoid hemorrhage, which distinguishable feature is patients say that the headache during subarachnoid hemorrhage is the worst headaches of my life, of your life. It also can be like secondary headaches can be due to brain tumors, so we should prescribe the CT scan. It can be due to meningitis. We should prescribe lumbar puncture. And in case of different hemorrhages, in particular subarachnoid, we also should prescribe CT scan to exclude these conditions. And if we exclude all these conditions, we can then think about primary headaches, which are not so severe. They don't lead to death. In common, they don't lead to some permanent neurologic deficit, but they decrease the patient's quality of life very, very, very severe. And of course, we can think about some ophthalmic conditions like glaucoma, like iridocyclitis, like some occlusion of the eye veins or eye arteries, which can mimic like cluster headache. So, dear students, that's all for today. The next time, I think Lena Konstantinovna will will teach you, will provide a class. So goodbye students, have a nice day.